doing in front of those people, because right now I see the beautiful Azim Sheikh. Love him to bits, but there you go. Okay, thank you everybody for joining. Thank you, Dr. Sheikh, for introducing me so nicely. I'm honored, honestly. This is too much. I don't see myself so special, but oh well, I'll take it. During COVID, it feels good. I want to talk to you guys today about the magic of soft tissue laser dentistry. There is so much to say about laser. I'm really passionate about it. So I try to include the basics, so those of you who are new to the subject get a little feel for it. And I could not help but to include part of the stuff that I'm super passionate about, which is doing those tongue ties on newborns. I'll talk to you a little bit about it, and I invite you at the very end of the webinar to ask if you want more information on this, because I did not go in total depth. There's a lot to know, but if you have a particular interest in that field, then I'll be delighted to talk to you some more, but I don't want to waste everybody's time if they're just more interested in regular laser. So let's get started. So Azim said a little bit about me. I'm from Quebec. I'm from Mont-Laurier. It's a very small town, so you probably hear an accent. I don't hear my accent. I think I don't have any. No, it's just kidding. I know it's there. I have a master's degree in speech pathology. I graduated from the University of Montreal in that field. I worked a little bit in that field as well and saw a bunch of different clienteles, and then I went back to school at McGill. I graduated in 2005, and just so you know, I learned also my English at McGill Dentistry, so that's why sometimes I make a few mistakes. My English is still fairly new. I moved to Ontario with my husband in 2006, and then I worked a little bit in different practices to see what's out there, and then I did my own thing. I opened my practice in Milton. So the practice that I own is called Milltown Dental. Those are some of the pictures. We renovated recently because of all the newborns that I treat. I needed to adapt for them and have nursing rooms. So this is the new Milltown Dental, and that's my team. The team grows all the time. It changes also all the time because we're a growing practice. So there's a lot of movement going on. Most of the people on this picture, so this is pretty much it. And when I'm not a dentist, well, you'll see me outdoor, hockey mom. I'm usually playing Snow White somewhere in the forest, or I'll be at the gym, and the only reason why I work out really is to drink wine. So now you know. And more importantly, I have two children, 12 and 8, Logan and Jeremy, and my lovely husband, Chris, who is a huge part of my practice and allows me to do what I love. And then this little munchkin you see there on the bottom right is Oliver, who's a new addition, and we've only had him for 2 weeks. So let's get to the meat and potato of things. Laser means light amplification by stimulated emission of radiation. You probably will never remember that anymore. I always have to look it up. I never really remember. But the idea about it is that laser is a form of light. It's a particle that will travel in waves like this. And the photon is its unit. And what you need to know about this is that it is qualified by amplitude and wavelength. Now, all these words are a bit annoying. I know we're going to go through a little bit of theory, but it is important for you to know this, because if you don't understand the theory behind your laser, it won't be efficient. A lot of people start using laser and they say it's not working. They'll call their rep and say, my laser is deficient. Well, it's not. The only problem that you have is that you don't know how you're using it. You don't understand your tissues and the theory behind it. So I'll go through it a little bit, and you can ask me questions at the end if it's not clear. So as you can see, there's this wavelength going on. It goes from one peak to the other, and then the height of that peak is called the amplitude. So what you see that goes vertically is amplitude. What you see that goes horizontally is called the wavelength. Now the amplitude, if you want to remember it, just remember me, I'm pretty intense, and my name is Jules. So you calculate this in joules, and it's the intensity. So if I was a sound and I wanted to make myself more or less intense, I would be more loud or less loud. In terms of the wavelength, that's more, I'm going to come to it. You're going to see the wavelength have something to do with the oscillation and the frequency and how efficient you work in your tissue. Okay? But the amplitude is the intensity, or how hard your laser will work. So the frequency, as you can see, is the number of oscillation that you have per unit of time. So if in 1 second you go really, really, really quickly, your frequency is very high. And if the wavelength are longer in between, then your energy is less. And that is very, very important in the laser field. You manipulate your hertz all the time to get more or less energy. So I said that before already, the change in the amplitude and the wavelength of your laser will change the intensity and the amount of energy. So a lot of the time, the patients will say, well, I don't want you to use the laser on me, Dr. J, because I'm scared I'm going to get cancer. So it's important to understand where your laser stands in that electromagnetic spectrum. The drawing that I have here on the screen, you'll see that, you know what, let me pass to the next one so you can see it better. There you go. So I made it bigger and I put in red, you see that red line on the right is where all the lasers are categorized. And you can see they're all on the visible side of the spectrum. So all the visible side of the spectrum is non-radioactive. So it's not carcinogenic. It's just light emission. Everything that's on the other side that becomes more on the ultraviolet or the X-ray side, I put it very big in green on the top left. It says ionizing, DNA mutagenic, cancer producing. So this is something that you might want to have plastified in your office to show them that all the lasers that we use are not dangerous. They're not going to get cancer from this, and you won't either. A few important words we have to know about laser is something called the spot size or the focal point. So basically inside the laser, you have a beam of light, you have an active beam, and there's a lens, a little bit like you know, photography or eyes or things like that. And when the lens grabs that light, to make a long story short, it will focus it, and then it will create a spot. And different lasers will have different diameters of fibers, and therefore your spot will be different. And that's why you can do dentistry with laser, but you can also do, you know, fat cell reduction with the plastic surgeons and all sorts of other laser treatment that we don't use necessarily in dentistry. So when your focal point is super, super focused, when your spot is very, very tiny, we call that the focal point, and that's where your energy is maxed out. And that's important to know because you will use that focal point when you look at your tissue to affect the tissue different ways. So for example, the one here on the left is called the Epix. I own this laser and I absolutely love it. It is a soft tissue laser. That one is, the focal point is at the very, very tip. So you almost touch your tissue. You have to be super close to get a reaction. If you step outside of the tissue, like away from your tissue, now suddenly your focal point will grow a little bit like a flashlight would do if you went against, like on the wall and away from the wall. And at that point, your energy is not as much, as more diffuse, and I'll talk to you about what kind of treatment we can do with that. The one on the right is a CO2 laser. These ones, we don't even get close to the tissue. You're always away from the tissue because the focal point is in a different position. So depending on the laser, you have to know where that focal point is because everything depends on your positioning to the tissue with laser dentistry. So a focal point, small spot site, super convergent. You can do incision, excision, you cut. That's how you cut. When that little circle is tiny and you get close, that's how you cut. If you step away and you do that trick that I told you about the flashlight, then now your beam is defocused, you're divergent, and now you can affect a bigger site. And now that's more for shallow ablation or even hemostasis or other treatments that we'll talk about. So this is the example that I was telling you. If you get closer or further away, we won't spend too much time on this. The other thing that's super important about laser is if your wave is a continuous wave when you use it or if it's pulsed. So to make a long story short, continuous wave means you press on your pedal, your laser shoots nonstop. It goes like this, and then you affect the tissue nonstop. If you pulse it, this is what I love to use the most because once you pulse it, what happens is your laser goes on, off, on, off, on, off, on, off constantly, and then it never really gets warm. It's a lot more comfortable for the patients, and that's the way you use it if you want to skip on local anesthesia, for example. So I put at the bottom some example, like if you think about how they do tattoos or sewing machine, that's kind of more pulsing. So I'm going to go through this fairly quickly because you probably won't remember it, but I put it in there in case we record this webinar or in case these notes are shared with you guys. I'm not sure. If you want them, I'll gladly share them. It's theory you kind of should know, right? So when you use a laser, there's different reactions to the tissue, and you need to know those reactions because it can affect your tissues in different ways, or it can even affect people around you in the room in a different way. So the effect number one is called reflection, and I think I forgot an L in there. I'm sorry about that. So what happens when it's reflected? The light hits the tissue and gets in another direction. So in practice, what that means is, this is the reason why with laser we use special eyewear. Because, for example, if your laser hits a metal filling or a crown or an implant, something like that, it will bounce and then it will end up in your eyes or in someone else's eyes. So it's important that everybody wears really, really good eye protection. The other reaction that we get is absorption, and that's the one we want. Absorption is everything with laser. It's absorption of light that does the trick. It's like the sun. The sun's a form of light. You absorb it, you tan. That's what you want, good for you. But with laser, different tissue will absorb the laser different ways, and it depends on their pigmentation, the water content that's in that tissue, and you need to know those things. So in practice, for example, you won't treat enamel and dentin with the same energy and with the same settings on your laser because the water content in dentin is much higher than it is enamel. So things like that. Same thing for if you're treating racial pigmentation versus nice pink gums, or someone who's super anemic and their gums are very white, then that doesn't react the same way, okay? The third one is transmission. Transmission, with what I do with my laser, I'm not like really concerned about it because I use mostly soft tissue laser, but basically it's how it penetrates and goes right through. So I think with CO2 is a bit more important, but if your laser goes right through a tissue that you're trying to treat, like, I don't know, like, you know, like going through water, like there's no resistance at all, then you have to wonder what it's going to hit after that and how it's going to affect the tissues that are surrounding what you're trying to do. And so that's why you need to understand it, because you can burn tissues around or you can treat too deep, things like that. And the scattering, the last one, is basically just like splatter. Imagine that you drop your glass of water on the ground, it splatters everywhere. It does that a little bit. It's a good thing for absorption. It kind of helps absorbing in different direction of a tissue, but the problem is it also transfers to the surrounding tissues, and sometimes you don't want that. For example, if I'm doing, you know, baby frenectomies, I don't want the heat to go outside of the frenum because I don't want to burn the floor of the mouth or things like that. Now, laser in dentistry, I'm not going to go through this very deep, very quick. You have different ways to classify them. Some people want to talk about how the laser is built and what's inside. Other people will say, oh, it's a soft tissue laser or a hard tissue laser. And other people will talk about wavelength. But in general, you'll hear diode. Diode always means soft tissue. And there's a very specific wavelength that you see here, 6655 up to 980. And depending on what kind of soft tissue surgery you want to do, you have to pick the right one. You have the ERIAG. Those are called erbium laser. They can treat both soft tissue and hard tissue. And the CO2 lasers are dinosaurs. Like, they're huge. They're massive, super, super powerful lasers. I don't own one of those, and I don't think I want one either. Like, it's intense. You have to know you have to be a laser dentist to own this. You have to be really proficient. So the diode laser, like I said, that's the one I have the most, that I use every day. I don't think I could live without my laser. It's attracted by the soft tissue pigmentation. So the more melanin you have, the more attracted it will be. Hemoglobin, blood, it's attracted by that color as well. There's tons of procedures you can do with that. I'll go through some of my favorites with you guys. Some of the disadvantage includes the fact that a lot of the laser experts don't think it's a real laser, because the way the light is delivered to the tissue, it's almost like it wants to become an electrocautery. I tend to disagree, but I see their point. We can go in more depth into this if you have questions about this. But in general, they're very affordable. They're not big. You can bring them from one room to the other. You can train your team to use them. There's lots and lots of procedures you can do in the office. It's very lucrative to have it. You'll pay for it very quickly, and it saves your life. Honestly, this little machine saved my life so many times I can't even begin to tell you. The erbium lasers, I do have one. I have this one, the light touch. They're wonderful. They're very versatile. You can do all bone surgery. You can do teeth. I've done some fillings without any freezing with that. It works well. The advantage is that it doesn't leave any smear layer. Everything is super disinfected and sterile by the time you're done. But to me, the disadvantage was that it's a little bit of a larger machine, and the time that it takes to take it out and bring it and get set up, I feel like because I've mastered the techniques around my injections, my patients are not scared of my needles, so I don't really need to do local free dentistry. I don't know. So I use it from time to time. But today I'm going to focus more on the soft tissue lasers, because I think if you're a beginner at laser, this is where you should start, because there's so much you can do in it, and you will have your return of investment for sure. This is the carbon dioxide lasers, CO2. They're massive, they're huge, extremely expensive, but they do miracles. I mean, some people don't even use drills anymore. That's all they use in their practice. So we talked a little bit about the benefits. You can use no anesthesia, no drilling. There's a lot less blood. It will cauterize, and it will create hemostasis very quickly. There's also a beautiful analgesic effect of lasers. So if you have someone with lots of sensitivity and, you know, those cervical lesions they have, like by the gums, you can actually desensitize with laser, and it works really well. There's a lot less swelling. The inflammation is less because it's all disinfected. There's no bacteria left behind when you use a laser. So the healing period is less, the post-op sensitivity is less. And I skip a lot of my sutures with this. For example, if I do a free gingival graft and I cut some tissue on the palate and I have a little bit of a bleed, I don't have to open a membrane of collagen and press for I don't have to do any of it. Just take my laser and I run it over, and it just cauterizes right away. It's wonderful. The patients are less anxious also because of certain stuff that you don't have to do, like needles and sutures and stuff like that. It helps you build your practice. When you say to people you have a laser, it's kind of cool. The patients really are excited about it in general. And like I said, my last point, you can save your bum. It saved me so many times. There's so many teeth that the decay was deep. I'm halfway into like the gums. I know the tooth is bummed out. I don't want to remove it. I want to give it one last chance, or buy time for my patients to put their money aside for an implant in the future. And I just want to buy a few more years, but there's bleeding everywhere. And I know my filling is not going to be great. Well, this saved me so many times. That's just one example. The disadvantage of lasers is that they're a little bit expensive. You have to pay for your training, you have to pay for the machine. They're very fragile, so you have to be careful. Sometimes the team is not necessarily as careful as you are, because yes, it is what it is. Accidents happen, and if they drop it or things like that, it can break. The rep support is not always there. You have to really do your due diligence when you choose a company, because the reps are MIA half the time. So you have to do your homework and do your courses and train yourself on your own, or find someone that knows laser that can help you train. Also, other limitations, that you can't really cut any metal with this. So if you have an amalgam or you want to cut a crown, lasers are not the way to go. Accessing decay between teeth is very hard. Laser is not like a drill. It doesn't cut sideways. You cannot do a side cutting with the tips. It has to be only at the very tip. So the angulation sometimes is nearly impossible to get in. So that's maybe why I haven't been as excited with my hard tissue laser as I am with my soft. It's very technique sensitive because of that. And like I said before, the time to take it out and organize and install it sometimes can be a bit time consuming, so some people get turned off. But for me, I mean, I would not live without my soft tissue laser. So these are all the things you can do, and then some. Let's go through a few of my favorites so that I can show you how exciting it can be. So the treatment of gingivitis and periodontitis for me is my number one, because my team is excited. My team is trained to use, and my hygienists know how to do this. Because we're not cutting, we are disinfecting. If there's any cutting involved, if we're doing any gingival removal because of like a pocket reduction, I do it. I do that. But if they're going to treat the pocket, at a different setting where it's basically just for disinfection, then they're doing it and they love it. And we have before and after pictures that we show the patients, and honestly, the difference is major. So I do Dr. Shake's program, which is called the STM, soft tissue management, which is very particular. And then we add this to the equation and we get ridiculous results. I mean, I haven't really needed to refer that much to periodontists. Sorry if there are periodontists listening to me right now, but it's working very well for our office. So this is an example. I need to let you know a lot of these pictures are not mine because sometimes my pictures did not show as well. There are other cases where I forgot the name of the patient that had the best pictures. So I borrowed some pictures online and I gave credit to the people who shared. So you'll see it on my slides, but you can see the before and after of someone who had gingivitis and very light pockets and see what happens after, like, say 3-4 weeks follow-up. It's wonderful. Another use another thing that I do in my office all the time with my laser is the treatment of cold sores and after saucers. I cannot even begin to tell you how many brides came to my office the day before their wedding. I mean, people who have cold sores know that they come out when they're on vacation or about to go on vacation, or you're about to get sick or you're stressed out, and any stress in life will get these little lesions out, and I can laser that off. We don't touch the tissue. This is one of those applications I was telling you about where you have to step out and then you just do this diffuse kind of like flashlight move on it, and it's so simple. My hygienists do it. You basically just do little circles around the lesion. You have to know where the lesion starts and ends, and there's different tests we can do with a Q-tip with the patient's feedback. But normally if we catch it when the patient feels it, but it's not out yet, honestly, it doesn't come out. And I have patients that we've treated 2 or 3 times and now they don't have it anymore. It's gone. My husband's one of them. So it's really, really nice to be able to offer that to people because cold sores are very debilitating for most. Gingival recontouring, I use that a ton because I do some cosmetic work. And gums are not always even. So you can take your laser and honestly, it's like a pen. Imagine that you take a pen and you just go around the gums and you erase what you don't like. It's that simple in some cases. What I'd like to warn you about, however, is you need to understand your biological width concept, because the gums are not just gums. Gums follow the bone, right? I'm sure you heard the bone sets the tone, like that kind of stuff. Well, you need to know where your bone is, because a lot of us get mistaken thinking we can erase those gums and it will stay. Well, newsflash, if you don't remove the bone and you were invading that biological width, it will grow back. So there have been cases that I've seen from online or courses where we've put beautiful veneers and we've recontoured those gums, and then the gums went right back over the veneer because the bone wasn't addressed. So you need to understand your biological width, but if you do, and let's say you have no issues with it, you can easily take your laser and get that result, no problem. Another thing that I do from time to time is racial pigmentation removal. So when people have a lot of melanin in their gums and they don't find it aesthetically pleasing, you basically erase it. You take your laser and you just go on top and you do the whole thing. It's barely any sensitivity for the patient, and it heals beautifully, like the picture that you see on the right. That's what I was talking to you about when we do free gingival graft. If you have, those are not my pictures again, but this is what it would look like once it's cauterized with the laser. So it's wonderful. It stops bleeding completely and you can continue surgery without wondering if the palette's going to continue bleeding for an hour. So I really like that. And it looks scary, but the patients really get very, very little pain with this, which is even better. Something that I do a lot, especially on children, is, when they turn about like 12 or 13, is a periculectomy. This is so easy with laser and so clean. You don't have to take your scalpel out. You just take your laser and you just do a little drop of Lido right in that bump, and then you just like shave it down and it's done. It's like so cool. Everybody gets happy because there's no bleeding. Kids don't like the word blood, so this is perfect for them. Another thing I do for orthodontists from time to time is I will expose teeth. So you see that canine on the bottom, like it was completely hidden, and then you basically just take your laser and you color. You just have to be good at coloring. You just color and eventually you see the tooth, and then you just expose it. You can put the bracket, no problem. There's no bleeding, so the bond is perfect. Exposure of implant is something that I have added to my to my needs since I've started to do implants, and it's amazing. You don't need your scalpel. You can find it very easily. You just basically take the tissue away around. There's no bleeding at all. Your impressions are perfect. It's a really, really nice tool to have. Access to deep cervical decay. You know, when these people have these deep cavities around their teeth and close to the gums, the retraction cord usually will be in your way, and then sometimes you do a filling and half of your retraction cord is stuck in your filling and you're like, damn it, there's a little bit of glue in my filling, and you have to shave it down and do it again. So with laser, you don't have to. And usually if the bone is not touched, and let's say you remove some gums, it will grow back really nicely as long as you haven't impinged on the biological width. You can really like laser the gum off. It will grow back, and actually it will grow back nicer than what it was before because of the bioregeneration properties that laser have. Another one that I really love is all these deep interproximal decay. So this is what I like to call the ugly dentistry. When I see X-rays like this, and I can see that I'm gonna have a hard time. I'm gonna invade the biological width. You can see the cavities already led to some bone loss. Cavities are very deep, and then I have to send that to an endodontist for root canal immediately after, so I don't want them to be ashamed of my filling. I have pride a little bit. I want the filling to look good, but when you look at the picture on the top right, you see the emergence profile is very wavy. There's a lot of contour to this tooth, and there's no wedge out there that will fill this up for you and create a nice contact. You can't do it. So the only way I found to do these is to laser off some tissue, freehand the first third of it until I have them close enough that my wedge will now create a good closure, and then I finish the job. That way I don't get bleeding, I can freehand it, there's no curvicular fluid, everything is nice and clean. So the picture that you see here, the first two on the left are the same patient, the one on the right is not, but I couldn't find what it looks like with laser. But if you see this cavity, like you know your gums are in the way. As soon as you start putting like a band in there, it's going to go under the gums, it's going to start bleeding. Like you can see, they tried the retraction cord, it didn't work, and then they took a drill to kind of remove the tissue that was in the way, and now you have this bleeding wound. Well, with laser, the one that's on the right, imagine that you had this cavity and not a crown prep. It would look like this. So there's no bleeding, it's nice and clean, you see your margins, and now you can work. Another example here, this is actually a real laser treatment. You can see the dentist had to try to save this tooth, buy time, or I don't know, and you can see they've used the laser to stop the bleeding where the tissue is the most irritated, so they can finally put their rubber dam on with the band, and so there's no bleeding. So the laser came very handy, and the final results are absolutely spectacular. This tooth is going to last probably a long time now. Another example, these big fillings where you have to like take your otomatrix, or you have to push with your fingers deep under the gums to manage to remake a wall and try to save the tooth. There's always bleeding like oozing underneath, and then you're like, damn it, I just etched and bond and now the bleeding starts. It always after the bond. I don't know about you guys, but me, it's beautiful until I put the bond. When the bond is on, it starts bleeding. But with laser, you don't get that. It's actually great. Crown and bridge impressions, wonderful. Instead of using these retraction cords that you push and damage your biological width, you can just clear them out, nice and pretty, there's no bleeding, your margins are all clear, and your impressions are great. Bleaching is another usage. I have, like I said, this Epic one. We do bleaching like this in the office. I mean, this picture is the ad for this. I think it's a bit far-fetched, but that being said, we do get really, really amazing results, and the patients are quite happy. TMJ treatment, some relief of that muscle tension. There's a special little insert that you put on your laser, and it really relaxes the muscles, and it removes all the tension and the knots in there, and it's been helping a few of our patients for sure. My favorite, ponting formation. You know when you do a bridge and you want your tooth to look like it's coming out of the gums, not like it's sitting on it? Well, if you take your drills and you just go at it and you create this pontic space, it's bleeding, it's messy, and the patients don't like it. They're a bit more in pain and whatnot. And this with laser is perfect. You just shape it the way you want. Hemostasis is achieved, and the healing is beautiful. Another application is what I was gonna talk. this is like my thing, my niche, my passion, my specialty, my baby with my laser is the frenectomies of tongues and lip. It actually started, well, those are pictures, we'll go through pictures later on, but basically that's what it looks like with laser. How did I get involved with all this, and how did I become this specialist of tongue? There's no such thing as a specialist, but the well-known person to do it is, well, first I'm a speech pathologist as well. So I guess that helps. I started to see little munchkins in my office that had speech issues, and I would tell the parents, you know, like the tongue tie is probably the cause, and then the parents were like, oh, well, we've been doing 6 years of speech pathology and nothing's been working. And so I'm like, well, what do you have to lose? Let's just try to do this frenectomy. And sure enough, it would work, because I've seen so many when I was a speech pathologist that I knew that was the problem. So I started like this. I got my name out like that. And then I got pregnant. I got 2 kids, and both of them were tongue-tied. Now, when you have a baby who's tongue-tied, the nursing goes down the drain. For most women, we can't nurse, it doesn't work. And what made me very, very angry at that moment is that there were no services. There was no service, there was nobody to do a frenectomy for me. The only thing I found was a doctor in a random hospital that agreed to do like a very tiny snip of the tip. I mean, it served no purpose. So I failed. And every single problem you can have with nursing, I went through it, and it was hell on earth. I don't wish that upon my worst enemy. So I decided that I was going to make it my mission to help people where I failed. I already knew how to do frenectomies. I already owned the laser. All I needed to do is train myself on newborn and train myself on breastfeeding and how it's going to help and why it helps, so that I can talk with the professionals that work in that field and not sound like I don't know what I'm doing, and also talk to the parents and make sense of what they're going through and why I can help. So a bit of anatomy. A normal frenum can attach anywhere under your tongue. It's basically that little fiber that runs from the bottom in the floor of your mouth all the way to underneath your tongue. You're a dentist, you all know that. But what you need to know is it should allow the full range of motion of your tongue, especially in the elevation towards your palate. So if you, I know you're all gonna do this at some point, you're gonna go look in the mirror, open your mouth nice and wide, and then get your tongue up and see where it goes. Now, a lot of us have some restrictions, okay? It doesn't mean you're tongue-tied, or yes, it kind of means you're slightly tied or slightly tethered, that's the real word, but it doesn't mean you're non-functional. So this is a very important point, right? You can have flat feet, but if you can run, walk, and be happy and be merry, you don't need a surgery, you're good. If, however, you're in excruciating pain and nothing's working for you, then maybe you go consult and maybe consider a surgery. So it's the same thing for tongues. So an abnormal frenum is when it's too short, too stiff, it's not flexible, or it's too thick, and then it prevents your full range of motion. So that can become your handicap. And the problem with tongue ties is that there are different classifications, and we'll look through them together. But for the same category of tongue tie, you will have 6 different pictures of it. So you kind of have to train your eyes and train your fingers to touch and feel. And no joke, you have to do the work. You have to train yourself. It's not so much something you can learn in the books. The more you see, the more you touch, the more you'll know, and then eventually you get a really good feel for it. So frenum classification, there are a few, but the 2 main, if you're getting involved in all these frenums on babies, will be the Kotlow classification. Dr. Kotlow is a dentist. He works in the United States. He's wonderful. He knows his stuff. And then the other classification is Scorilos. Scorilos is more for lactation consultants. So IBCLCs, like you see in my notes, stands for something like International Breast, I always forget, I can never remember acronyms, but basically those are the ladies that will help the mothers and the babies with, you know, the latch and positioning and how to breastfeed properly. So in dentistry, we use the bottom one, the class 4, class 3, class 2, class 1. When you hear the word type 1, type 2, type 3, that's Scorilos. That screams lactation consultant. So it's important to know, because you'll get referral from a lady who's a lactation consultant, and she goes, oh, Dr. J, this is a type 4 tongue tie. And for me, I have to automatically say it's class 1. They're reversed just to make things complicated, okay? So we're gonna look at them together. The tongue tie class 4, or what the lactation consultant called type 1, is the most obvious. So we've all seen at least one in our life. Basically, it's at the very tip. The tongue is heart-shaped. it goes nowhere. It's you know, there's all sorts of issues that arise with this. Most people that have this kind of tongue tie will have some kind of problem, and usually they'll either be treated or they'll compensate, or we'll hear it in their speech, something happens, okay? But some of them don't have any symptoms, I've seen it. The idea is if your frenum is super short, but it's really elastic, like an accordion, then you're fine, you're functional. It just looks tongue-tied, but you're really kind of not, okay? The second one is called the class 3 or type 2. So that's basically the same as the class 4, but now you're a little bit behind the tip of the tongue. So it's still short, it's still tight, it's still preventing elevation, extension, and movement, but you don't necessarily have that heart-shaped tip anymore, and it's past the tip, but it's still kind of in front of the mid-tongue. So these two, we call them anterior tongue ties, okay, because they're in the front. When we hit past the middle of the tongue, now we fall into class 2 and class 1. Those are called posterior tongue ties. So a posterior tongue tie very often will be missed because sometimes it doesn't show. The patients don't have as much symptoms about it. They're not as affected by it for the most part. But for nursing, these are the worst ones because they're snakes. Like, they do things to nursing and nobody knows why these problems are happening, because you have to be trained to recognize these tongue ties. You have to know your anatomy, and if you don't, you'll miss it, and then the whole nursing thing will go down. The mother will try everything, nothing's going to work. And so the class, hold on, this is my class 1. So the class 1's the hardest to see because there's no frenum. I don't know if you can see, there is no little rope. So most of the doctors, most of the people that are involved in the baby's life will say, no, your tongue is fine, there's no frenum. Well, there is one, it's just hidden. And the picture on the top right, you can see we take our fingers and we push on the floor of the mouth and we isolate that rope, and then we see how tight it is. But normally the sign that it's there is the baby will cry and the tongue will be scooped. It creates this little bowl. If you think about a baby crying, the baby who cries, their tongue needs to go up and block the entire airways. If you're born in Africa, for example, where there's lots of little bugs and flies around their little heads and they cry. I don't know if you've ever heard a baby cry, but they take a lot of breaths. It goes, wah, wah. They always take a breath. And so if there's flies that can go in, they can choke. So the tongue is a protective thing that will go and block the entire airway, create a wall in front, nothing goes in. But if your tongue is scooped, you can see the baby on the top left, there's plenty of space for a fly to get in there. So that is not normal. You don't want to see this pattern, and especially the fact that there's like a little divot at the tip of the tongue. This screams too tight, okay? But they are very hard to spot. There's techniques where you can push on it and see that the tongue actually goes down. We call that the Murphy sign. There's a lot to know about this field. If you have an interest, reach out to me. I will train you if I have to, but there's a lot involved in this stuff. But very, very important to know and recognize when there's a problem. You don't necessarily need to know how to treat it or whatnot, but you need to know that there's a problem so you can tell the mother where to go, because by the time the baby is 2-3 months, they have so many bad habits already around their bad nursing that it's almost too late. There's so many failures if they're not caught early. Now this, I don't know what it is. I call that alien, freak, clown, crazy talented mutation. It's not a tongue tie, it's my daughter, she's fun. But anyways, the only thing you need to remember is her mom's awesome. Breastfeeding nightmares. So let's talk a little bit about the issues with tongue ties in general. I'm gonna touch mostly on babies because that's what I do, but a tongue tie is a tongue tie. It starts when you're a baby, the problems are clear, and then they develop, and then they grow, and then you grow into a kid that has these problems, and then an adult that has even more. So I'll try to explain to you where it's going. But in babies, the first thing that you see is nursing issue, and that's your dead given that there might be a tongue tie. And if we catch it so early, then we can avoid like a long lifetime of issues. So what does it do, this tongue tie, to the nursing? Well, if you think, I'm going to put a glove on. It's convenient I have them because of COVID, but I'm going to show you with my hand what a tongue tie does, okay? And I do that to the parents so they understand. So you have, let's say, your tongue. Normally, your tongue is supposed to come out very easily of the mouth. It's supposed to lift at the back to, let's say, pronounce the sound k. You'll feel your tongue goes k, and it lifts at the back. You also need to be able to lift the tip. And then basically nursing, what the babies do is they stick their tongue out and they pump the breast by a wave motion. So it's like a mermaid tail. Now I do this. I said, let's pretend that you're tongue-tied, okay? So the tongue-tie can be here. That's a class 4, class 3, class 2, class 1. It doesn't really matter. Tongue-tie is a tongue-tie. So let's pretend I'm a class 1, okay? I'm right here. Now the baby's trying to stick their tongue out. See how they have to fight? That's hard. They'll be able to do it 2-3 times, but then they're going to fatigue. Then they need to lift the back of their tongue to push on the breast and pump it. Look, I'm struggling again. And then they need to open their mouth wide to get on the breast. Look, it's holding my jaw. So all of this is a problem. So if we actually cut this off, then we have a new range of motion. So the limited mouth opening prevents the baby from going deep on the breast and getting the tongue in the right position. The fact that you can't extend out, they can't go underneath the nipple, and now the tongue is here and then the gums are here. So the babies start like gumming, we call that gumming, and then the mother is in hell. It's so painful, you don't even understand. And then elevation of the tongue, if it can't happen, you can't pump the breast, the milk doesn't come out, your palate is not sealed, so now the milk goes everywhere, it goes on the side of the mouth, baby's choking on it, and then it's a big array of like issues. So that's why tongue ties and nursing are intimately, is that a word? Yeah, it is, related. So this is a picture to show you on the right, super shallow latch. You see how the baby is closed. They're basically taking just the nipple. They're gonna suck the mother like a straw. And the nipple is not meant to be sucked. The nipple is just the shower head. It's supposed to be deep down in the throat, delivering the milk in the throat. It doesn't go in the mouth. I always say to the parents, nursing is just like when you're a college student and you take that, you know, that big tube of beer and then you just drop the whole beer and then you didn't even swallow, it went down. I don't even know how people do this, but that's what nursing is about. So on the left, the deep, deep latch, wide, wide, wide open, super, super deep on the breast, and the tongue is just doing the pumping and the milk comes out for free. It's actually very pleasant for the baby and the mom when things go well. So failure of nursing on the infant side is dramatic. The baby gets frustrated, they're hungry all the time, they're losing weight, they fatigue. How can you work through this resistance all the time? Go put a band of elastic between, you know, around your thighs and walk all day. You're going to be exhausted. There's going to be a point where you say, I just have to sit. I can't do this. So these little munchkins are like 2 days old and they have to force through this elastic band to get food. It's brutal. So they're nursing all the time. Those are the moms that are like having their babies at the breast 24/7. They have no life. They sleep at the breast, they cry all the time, and then they get colicky and they have all sorts of digestive issues because they are unable to extract the real milk that we call the hind milk. Because when you nurse, there's first a very liquidy, watery, easy to take out form of milk, which we call the foremilk, and it's basically water and sugar. And the other part is the milkshake, but you have to nurse properly to get that out. If you don't, you only get the water sugar, and then you get like colicky and you get diarrhea, and these babies are not doing well at all. They're regurgitating constantly because they swallow so much air. They're congested. It goes back up their nose when they regurgitate, so all that sits in their sinus. It's a mess. And the mother feels frustrated. She feels inadequate. She's like, why can't I feed my child? What's wrong with me? Meanwhile, her breasts are in pain. They're bleeding. She has mastitis, blood ducts. She has no time for herself because all she does is feed her baby. The husband feels hopeless. He wants to help, but he can't. And then they start fighting. Trust me, they fight. I fought with my husband about this. And the mother doesn't sleep, which you know what happens to a woman who doesn't sleep. And then poor child, mother bond. I mean, it leads to depression. You can't even avoid it. So this is why I'm really passionate about this, because as dentists, we see moms and we see pregnant women, and we actually see them more often because we're supposed to put them on 3 months for their period. And then we can kind of like tell them, hey, if you have issues with your nursing, did you know, and just give them a little pamphlet, because guess what? The doctors don't. and the prenatal classes don't. So we are like in a position to help these moms not feel so inadequate and not feel like it's all their fault, because that's what I was told. My doctor told me it's your fault. Your breasts are too this or too that, and you're not doing it right, you're not latching, whatever. It was always my fault. It wasn't. So these moms need to know. So when do you treat babies? You treat babies when there's symptoms. If there's no symptoms, if everything else they've tried, like body work, osteopath to release this, the lactation consultant couldn't figure it out, nothing is working, you treat. Or if there's no nursing issues, but you see the tongue's like, there's going to be some speech issues with that, or we're going to have other issues, then sometimes it could be a good idea to treat right away. The other risk of tongue ties, let's talk about how it can affect everybody in general. Increase of decay. Okay, let me just backtrack a little bit. The reason why I'm going through this is because I had to justify all this to the insurance companies, because eventually the insurance companies stop wanting to cover this when we do it, because they say we're not lactation consultant and we shouldn't treat nursing. My answer to them is I'm treating a lot more than nursing. There are tons of risk involved with tongue ties. None of them will kill anyone, but they are a big deal. And so I want to run you guys over them because they're very important for us as dentists and for people in general. So increase of decay in gum disease. Think about your tongue as your natural toothbrush. It's covered with these papillas and like this, and you scavenge all day long. We don't even realize, but we do this all day long. And think about the moment you have like a piece of rib stuck at the back or popcorn. What do? You are good. All day, you're going to do this until it's gone. It's going to drive you mental. And the reason for that is our brain is not dumb. We know that if we leave food behind unattended, then we're going to get cavities and gum disease. Well, newsflash, people who have tongue ties can't do this. They don't self-cleanse. They don't learn to self-cleanse because their tongue doesn't go there. So if you don't learn to self-cleanse when you're about 1 to 2 years old, because that's when it happens, when your teeth are coming out, then you're never going to do it. And then those are the people that you know that once in a while will stick their finger and like remove their food with their finger, or like they're always covered in food and things like that. So it's a big deal even for adults. Speech issues, I'm sure nobody's oblivious to that. If you have a tongue that is restricted, there are tons of sounds you're not going to be able to make. And these children get bullied, you know, and a lot of them will end up with learning delays. And when a child becomes conscious about an issue they have, then it becomes a psychological thing with speech, and we call that stuttering. Okay, so stuttering is not something we're born with. Stuttering is something that happened and your brain gets aware of it and you start panicking. So you start switching your sounds or repeating them, or you start like hitting your head or your thighs to get the sound out because you think you're gonna stumble on it. It's not something that you're born with. So these are examples of revision that we've done on children. You can see on the left, it's super tight, and then you can lift all the way to the palate, same thing on the other one. And usually, if they have issues with their speech, it doesn't take long before the speech is corrected. Very often in my office, we see the problem solved within 15 minutes as I'm giving the instructions to the mom or the dad. My assistant is practicing a little bit, playing games, and then the sounds are fine. So honestly, it's really efficient. Swallowing issues are big with tongue ties. Now, here's something I want to tell you. We don't choke when we're tongue-tied. We are at risk, and it starts when you're very, very young. The babies, when they take the milk in, they'll choke a few too many times on the milk, but we're smart people. We don't let ourselves die. So the brain takes over. Okay, so as much as we are more at risk with our tongue-tied for choking, we just don't. Because here's what happens. You develop a super, super strong sensitive gag reflex as a protective mechanism. Basically, your brain says, okay, the tongue is not protecting the airways, so I'm taking over. And what I'm going to do is I'm going to reject everything that's suspicious, okay? So everything you put in your mouth, you gag it. So these babies take forever to transition to solid because you'll try one puree and they'll gag on it and regurgitate it, and they look like they're choking, but really what they're doing is preventing choking. And what that does is over time, it will lead to being super, super, super picky with texture and food, because your tongue knows that you can choke, so it will select textures that are safe. So all the people in your environment that you know that like their food separated, you know, the meat on one side, the potatoes here, the rice is here, and then the sauce is on the side, and they eat all this, and then they go to this, and then, oh, that gags me, or don't show me this texture, it gags me. That kind of behavior screams tongue tie, because that's a protective way for them to manage their texture one at a time so they don't choke. So you'll have people that will say, I love vegetable soup, but it has to be in a cream. I don't want the pieces in there because that gags me. So that kind of behavior, you know it screams tongue tie, okay? Another problem with tongue ties is that the formation of your jaw and your mouth is changed. It starts at the breastfeeding. Breastfeeding is extremely important for the development of your palate, your arches, your jaw. There is a movement that is needed for the proper development of the head and neck. I have a few chiropractors and osteopaths that I work close with. They can pinpoint, just looking at your face, they'll say, you're breastfed, you're bottle fed. They know right away just from the head and neck and our positioning if we were a breastfed baby or not. So it is an important thing to fix early so we avoid all those jaw issues. And that might be one of the sources of all the jaw TMJ stuff that we're treating right now, all the full mouth rehabs we have to do because of grinding and punching. God knows, maybe it starts at the nursing, I don't know. What we know is when you're tongue-tied and you're nursing, you create this deep palate. For some reason, the tongue is moving different and it deepens that palate so much. It will affect the aesthetic of your face. When you deepen your palate, your arches will narrow. And when your arches narrow, your face shape changes, and the way your teeth erupt also change. And these children are often in need of expanders and a lot of braces, a lot of years of braces. And they normally are mouth breather as well, which will change the position of their neck, and they all end up like this. If you go in a restaurant and you look at all the kids on their iPad, you'll know which ones are tongue-tied and which ones are not, because they have their mouth open, their jaw is hanging, their eyes are hanging, everything's hanging on a mouth breather. Tongue thrusting is something we see with tongue ties as well. And you can see it's pushing the teeth out, it's narrowing the arch. You get an anterior open bite from this. Your teeth are not erupting the right way either. And like I said, the jaw issues, clicking, pain, migraine. And this, by the way, is usually what brings an adult tongue tie to my office, because they've tried chiropractor, osteopath, myofunctional therapist, massage therapist, marijuana. There's nothing they haven't tried. They're in excruciating amount of pain. And then one day they meet someone who knows tongue tie, like a myofunctional therapist, and then they end up in my chair and they're like, apparently I'm tongue-tied. And it's usually one of those like posterior one that nobody has been able to identify. And that creates tons of tension everywhere in their head and neck, and it diffuses to their back and their shoulders and everything. And the moment we release this, they're good to go. And even their posture changes. I have a slide I'll show you later. Sleep apnea is huge on tongue-tie. The way this works is when you deepen your palate, I told you before, it elevates the floor of the nasal cavity. So if you take your palate and you push it up, suddenly you have less room here in your nose to breathe. So you start mouth breathing. And that, like I said, will change your head and neck and spine position, and it can lead to sleep apnea, okay? And then you're more allergic and attention deficit disorder. If you have sleep apnea as a kid and you're like not sleeping well, you wake up, you're exhausted. And when you're exhausted and you're a child, you bounce off the walls, you're not paying attention to the teacher, and there's a stigma. And I wouldn't be surprised if a lot of the children nowadays that are called ADHD and all that have a form of sleep apnea. And if we were to pay attention a bit more to that part of their problem, maybe we would avoid all these medication we give them. Another reason why tongue tie creates sleep apnea is because when you fight through this band all your life, well, your tongue is a muscle. Last time I checked, when I work out, my muscles grow, and so the tongue does the same. Eventually, if your tongue gets too big, if you look on the bottom right, this is kind of like the Malampi cat stuff. It basically tells you how much of your throat is available for air and how close it is. It can lead you to blockage of your airways because your tongue is bigger. And sometimes you'll see this with scalloping of the tongue, like on that picture. That's usually a sign that the tongue is on the bigger side, or that there's clenching and grinding. But we don't know which one came first, right? Are you clenching, grinding because your tongue is big, or your tongue is big because you are? I mean, at the end of the day, you need to know if there's a tongue tie, because that can be corrected. Other issues, think about you're a child, right? You want to lick an ice cream cone, you can't. By the time the ice cream comes to your tongue, it's up your nose. Everybody laughs at you. You want to catch snowflake, you can't. You want to play a musical instrument, you can't. Funny faces, you can't. There's, I write kissing in intimate relationships. I mean, it is a funny thing to write, but just so you know, I've had 3 male patients in their 20s come to me, very shy, beet red, not able to tell me what their problem was until I figured it out. And I don't know, just read between the lines, but the wife sent me a nice bottle of wine after that. So, I mean, it is a problem. It's important. Relationships are important, and you need to, you know, you need to feel like you've got your stuff together. Emotional factors, when you have a lot of stress from, you know, being laughed at or whatnot. And in elderly, it's important to know these things, because when you put a denture in, if their tongue is tied, they won't be able to hold their lower denture. I don't know if you're aware, but most lower dentures are held by the patient. They're not held by suction. The patients develop a way to hold them in place if they're not held by implants. Now, in the adult tongue tie, if the adult is functional and they don't have a complaint, you don't treat, because a frenum surgery in an adult is more on the painful side than it is on the kid. The reason is very simple. The more you use an organ, the more you develop innervation in it. Think about people who became blind overnight. Eventually they hear better. So the body's well done that way. The more you use something, the more innervation you have. And we have more surface area as well. So it's not a super comfortable thing to go through. Even with laser, it's been uncomfortable. So I don't want to put my patient through something if they don't have to be put through it. That being said, it's also extremely difficult to change your ways. If you've been doing something like speaking or eating, or you've never self-cleansed your mouth or whatnot for 20, 30 years, what makes you believe that you're going to change overnight because it gives you range of motion? It doesn't work that way. There's a lot of physiotherapy needed around it, and most adults don't have the time nor the patience to tackle this beast. So my mojo on this is do no harm, don't fix what's not broken. If your patient is fine with their tongue tie, leave them alone. They're fine. I warn them, I tell them they're more at risk for cavities, so I'll put them on the 3-month schedule instead of 6. I'll give them more tricks to clean up, and I'll tell them where to clean up and where they're forgetting. And that's about it, really, at the end of the day. This is an example of an adult that is treated. You can see her posture on the left, and then her posture on the right after treatment. It's pretty dramatic, but this we see all the time. And also the opening. This is a little tool that we use to measure aperture, and it's very limited on the left. And once we treated it, there's a lot more range of motion on the jaw opening, which means she can finally eat a hamburger or sushi, which is great. This is something that we see on adults. Sometimes they're functional, they're doing great, but these little lesions come up, and that happens because it's rubbing or getting caught between the 2 front teeth. So when that happens over and over, it gets bothersome, and then we can just treat. This is an example of an adult frenectomy that was treated before and after. You can see the range of motion is wonderful. And same thing here, very, very dramatic difference between the left and the right, okay? And the healing on the right is not complete. This person will have to do exercises for another 2 weeks to be sure there's no relapse. So surgical option, how do we treat? There's different ways of treating, but the main 2, there's snipping. We're not gonna go deep into this. Basically, you take your scissor, you cut. It's that simple. We don't use anesthesia most of the time, especially in infant. It's quick, it's 1, 2, 3 chop. It's like a paper cut. It is covered by OHIP if it's done by a doctor, not by us. And as long as you stay within the anterior portion, so the visible frenum, there's not much blood vessels and nerves in there. It's basically just skin. You're good. But the problem with this is it's usually too conservative. So if you're trying to get results for nursing, for example, this kind of treatment I find is not super efficient unless the person is extremely, extremely knowledgeable in anatomy and they're not scared of the posterior zone in which you have glands and fat pads and blood vessels and nerves. If you are a newer dentist, you're probably even better at anatomy than all of us older dentists, but just a friendly reminder that the very front of the floor of the mouth is where blood vessels are important, and on the inside, hiding underneath, that's where they are. So right where we treat, there's not much going on. I have yet in my practice to see big bleeding or any nerve damage that leads to tasting problems or staying numb, you know, like the paresthesia. I haven't seen that yet, and I've been doing this for 7 years. So I don't think that the area where we work is to be too concerned, but you have to know your anatomy and you have to know where to go and where not to go, and you have to recognize when it's time to stop. So training is key, but don't worry too much about where we're working. It's not too dangerous. The laser surgery is the way I do things. I do it on babies, on older children, on adults, on anybody. There's never any general anesthesia involved. As a matter of fact, you can't. You cannot use laser and GA because of the tube of oxygen, and you cannot have oxygen and laser because it's a source of light and heat and fire. So it can be dangerous for their lungs. So normally we don't do GA for this, but a bit of local anesthesia sometimes. On babies, no, I prefer not to. I give the choice, but I prefer not to because there's a condition called methemoglobinemia that can affect babies under 2 years old, and it can be lethal. So I prefer no, and the parents usually don't want it either. And one of the benefits of not freezing them is that you can put them on the breast immediately after and they're not numb, so they know what they're doing. If they're numb, they have no idea, and they're panic and they can't soothe, and then they're salivating everywhere, and they're like, it's a mess. It's much better not to, I find. The frenectomies are better. The babies react much better too. It's fairly quick. It's between 10-15 seconds, you're done. And there's no papoose or pinning down. Basically, you just keep the hands down. I just don't want the baby's hand to grab my rope. They can move their head. I follow them. I lift my foot. I stop. I go back. It's a pretty kind procedure. It's not too dramatic. But it is best performed by someone who knows what they're doing, knows their tool, and understand babies. And you need to be able to deal with scared parents. A lot of them is their first baby, and you know, their first baby, God forbid, they wash their hands 6 times, and then they come in with like 6 luggages. Their baby is everything. So you don't have room for mistakes with babies. You have to have a pretty strong heart to treat those families, but it's actually fun. You make a lot of new patients. So a treatment of a frenectomy on an adult will look like this. So, well, that's not an adult. That's actually a kid, like in probably like early teenage years, I would say, like 11, 12. So on the left, the tongue is tied, and then it was treated. You can see the tongue lifts much better. And then you see this big white patch. That's very normal. You need to warn the patient that this will happen. It's called granulation tissue. If you remember, it's basically just healing tissue. There's nothing wrong with this. It's not an infection. Infection would ooze out. You'd see pus coming out. It would be red and swollen, and usually comes with a fever and a lot of pain. This white patch is not painful at all. It's just very annoying because it's thick. So think about putting a piece of popcorn underneath your tongue and live with it. That's what it feels like. Then it heals beautifully. The granulation tissue is gone, and then you have a normal tongue that can lift, no problem. It can also be very panicky to look at when you do it. Sometimes it looks like a massive hole. I've seen those. I have panicked. Don't worry, we all do. It's pretty scary looking. Sometimes when the hole is massive, I choose to suture it so that it heals nicely and I don't have to depend on my patient's exercise. And I will talk a little bit about the exercise at the end, but exercises are everything. If you don't exercise these wounds, the body will just reconnect. I mean, paper cuts reconnect. If you think about, you know, a C-section and we put it together, it reconnects. Our body heals that way. That's called primary intention healing, and that's the best way to do it. You just take this healing phase, put it together, and we're back. We're friends again. If you want to keep it open and you want it to heal open the same way, let's say you fall off your bike, you scrape your elbow open, there's nothing you can reconnect, it's just raw, you have to wait. You have to wait for secondary intention healing, which means now your body's got to work. Now you got to make skin. That means you have to bring all the blocks for construction and for that skin, and it takes time, and then it inflames and it throbs and it gets tighter, you know. So during this phase, it lasts a good 4 weeks for this to heal. I tell my patients you need to stretch this like every 3 hours religiously. It's not a long stretch, and on baby it takes like 10 seconds, that's enough. But it's basically like a good stretch, like you would give yourself after a workout, like you're a bit stiff, it's a bit sore. The next day after a workout, right, you're kind of sore, but you know, after you stretch, you feel better, you feel looser. That's kind of the same idea. They have to do this for 4 weeks, every 3 to 5 hours, okay? So that's what I just said. Basically, my mojo is treat only once, do it well. If you're not sure, refer to someone who's sure, because this will heal very quickly, especially in babies. They heal twice as fast as we do. And a retreat is no fun. A retreat is hard on their wallet because they have to pay. Obviously, we have time to cover, and it's usually not our fault if it reattaches. It's hard for you to do because you don't want to put the baby through this again. There's scar tissue. Scar tissue is very white, and I told you before, lasers like pink and melanin and color. White doesn't respond so well. So now you have to up your energy, right? Your joules, your intensity. So now you may want to freeze at that point. So there's a lot involved with retreats that I just don't like. So I tell the parents and I drill them, we're doing this only once, and you put your strong hat on and we're on it. So that's what they need to do. And this is what it looks like after maybe, I don't know, 4 or 5 days. This is a picture from Dr. Gahiri. If you want to take any course or you want to know anything, he's amazing. His website is absolutely spectacular. Go see it if you want to learn everything about this stuff. He's wonderful. But you have to stretch, and you cannot stretch gently. So if this is the floor of the mouth and this is the tongue, we're not stretching like this, because this means you're going to lose all this. We're stretching all the way to the fold, all to the very, very end where the tongue has been released. If you don't, then you will have a partial reattachment. So it's inevitable. It happens every time. So anybody who tells you exercises are not needed, go back to medicine. Go back to your basics. Go back to primary healing, secondary healing, and think about what tissue would do. This is very logical. It's not me who invented this stuff. Primary intention happens no matter what. Now let's talk a tiny little bit about lip tie. Lip ties are involved in nursing very often. Lips can be classified in 4 classes as well. The class 1 is the one that looks perfectly fine. It's barely visible. You don't see much. It's very high up past the mucogingival junction. The class 2 is very, very close. Attachment into the area where the free and the attached gingiva meet. So right at your mucogingival junction there, if it attaches there, we call it class 2. Normally, these 2 classes, you can flange like really easily and moves well. We normally don't have much issues. I don't think I've ever treated a class 1 or class 2. I don't see the point. Class 3, now it's right, it's kind of in that attached gingiva zone. And depending where, I'll test to see if that flange happened. I want to see that lip move easily, right? If it does, I might leave it. If it doesn't, if it's really impinging on nursing or whatnot, then I might do it. The class 4s are the real ones. So the class 4 and the class 3s very often will look the same. The difference between them is the class 4, when it's a real lip tie, it doesn't attach to the tissue. It attaches to the tissue, through the tissue, into the bone. And that are called the real lip ties. So what you need to know about lip ties is they will usually self-correct. Give it some time. It will go. And the reason is simple. Pretend this is the arch of a baby, okay? And this is the frenum that attaches like a class 4 right here in the tissue. When that baby will grow and have their adult teeth, the adult teeth will drag the bone down. You know, our arch length grows, right? So it goes like this. The frenum is here, it looks lip tie. And then look, the bone's coming down with the teeth, but look at my frenum, it's up here. So it basically rides itself up. It looks like it's riding itself up. Basically, it stayed there, the bone came down. Now, pretend it's a class 4. Now it's attached here, but it's in the bone. The bone comes down with the teeth. Look what's happening to my frenum. See how it's being dragged with it? So that frenum cannot be just split superficially with a soft tissue laser. It's not enough. You have to detach it from the bone. So when nursing is involved, I tell the mom, yes, the lip is affecting your nursing because you want to have a beautiful fish lip that creates a nice seal around the breast. So we need to treat. But you may need a retouch later on if it's a real lip tie that goes in the bone, because I am not removing those fibers from the bone. And when the lip is going to move perfect, your dentist in the future will be very confused because they're going to wonder why we have a space between the 1-1 and the 2-1. I think it's 8 and 9 in the US. Why is there a space there if there's no frenum? And then the mom needs to say, because that frenum was released superficially, but the fibers are still stuck in the bone. Sometimes they wear off, sometimes they disappear, sometimes they don't. It's hard to predict. You'll only know that when the child is older. So this is what I said here, real class 4, attaches in the bone, soft tissue frenectomy not sufficient, the space between 1-1 and 2-1 will persist. But normally these frenums that will leave a space as an adult, I'm talking about adult teeth, it runs in family. It's very rare that you'll have a child that has that space and the mom or the dad or the uncle doesn't have it. It's quite rare, and I haven't seen many. And normally in baby teeth, the parents always come and they want to do a lip tie when they look like this, that munchkin that you see on the picture, because they're worried about the space between the teeth. And my answer is, let it be. The spaces between the teeth are wonderful. That's exactly what you want. You don't want the teeth closed when they're babies because they have no room for the adult teeth. This is room for the adult teeth. I'm fine with it. Leave it. The worst case that can happen is they're going to learn how to walk, they're going to be a bit rambunctious, and they're going to fall and it's going to rip, which I like to call the free frenectomy. So it's not a big deal, let it be. And I tell the parents, if you get that free frenectomy, it's gonna bleed, it's gonna swell, put some ice, give them some popsicles or whatever and move on. It's not a big deal, you actually don't need sutures, you got yourself a free frenectomy. As a matter of fact, stretch it, keep it open, it will heal beautifully, okay? So normally they self-correct. So for example, something like this, you'd look at this and say, oh my gosh, there's like tension, it's blanching, I will treat this. Well, for me, when I look at this, there's no decay on those teeth, there's no food trap on each side of the frenum, the lip is flanging beautifully. Yeah, there's a bit of tension right now, but I don't see the point of treating this because that child is asymptomatic, completely functional, and I look at the eyes of the child when I lift the lip. If they're going like this and they start crying, I know the tension's too much. But if they're happy and I can go up and down the way I want, I like to give it the benefit of the doubt. Worst case scenario, I'll treat when they're 12. And you know what? It's going to be 10 times easier. I'll freeze it a little bit. I'll go down to bone while they watch Paw Patrol and we're happy. Much easier for me if there's no issue, okay? If there's nursing issue, I do. A case like this, again, is it really the lip tie that did this? Look how high I can lift that lip. I mean, if I'm a mom and I lift that lip, and I brush those teeth, those cavities shouldn't be there. So to me, when I look at this, if the lip lifts really high, that's not because of the lip tie there's decay, this is because of the oral hygiene. So I tweak the oral hygiene with the parents. That's what I normally do. And I leave the lip alone. A case like this, different. So these are adult teeth coming in, lateral coming in, and you see how this tooth is tilted sideways. It's trying to close, but it can't. It's starting to deviate, and I can see the frenum is really in the way. It's really thick, and I'm trying to lift the lip. I can't even take a decent picture. So that, to me, is a class 4 to treat. And no, we're not just doing the superficial release. We are going down to bone all the way to the incisive papilla on the other side. It looks terrible. I didn't find a good picture to show you, but it looks like a crater. It really does, but it heals beautifully. And guess what? Most cases that I've done did not even need orthodontics to close the teeth. It's automatic, close on its own. The laterals will push those centrals where they belong naturally within 2-3 weeks. It's super fast. So basically that's what it looks like when it's done. Superficial. This is a superficial release. We didn't go down to bone. When we go down to bone, you can see all the way down, all the way between the teeth, like a big crater. So if you're going to remember 2 things, you're going to remember that thing 1, as long as the tongue has full range of motion, the frenulum does not impinge on any normal activity. It's a normal frenum, don't treat. Okay, I don't care what it looks like. Work on function and what this patient is going through and what are the risks. Thing number 2, train yourself. That is the most important thing. You have to take your courses. You have to know how your laser functions. You have to know breastfeeding if you're going to touch babies. You have to be a kind person and be super patient, be a bit of psychologist around the moms. You'll have crying moms. You'll have scared people. You'll have fainting parents. You have to be ready to tackle this, but it is a wonderful, wonderful, wonderful field to be in because we really honestly, I would love to call it saving lives because I've been through the pain of all this. And if only I had me back then or someone like me to treat, oh my gosh, I can't even begin to tell you how it would have changed my life. You also have to build your network, because nursing is not just nursing. There's latching, there's the mom is probably in postpartum depression by the time you see her. There's a lot of people that need to be involved, and this tongue has created a ton of tension. So now you need to have a chiropractor involved, and not just any chiropractor or osteopath, those who treat babies and understand the anatomy of a baby. That's important, okay? And please, there's so much people out there that just do it because it's lucrative. Don't do that. We're talking babies and families and new moms here. It's not a money thing. Just do it because you care, and the money will come. That's a very important point. I'm sorry I have to mention it. It's a bit of a disgrace that I do have to mention it, but I see a lot of crap. And if there was such a thing as a thing 3, I would say build your network. You have to have a lactation consultant on your side, a chiropractor, a pediatrician. The midwives need to know who you are. You have to be trained. A speech language pathologist is helpful sometimes if you're treating older kids. A dentist or an orthodontist, very helpful if you need to reopen the arches and whatnot. Myofunctional therapists are great at relearning how to breathe, relearning how to suck, relearning how to swallow. If you find good ones, they're wonderful people too. And on that note, I hope you were not too bored. I want to thank Dentistry Academy for allowing me to speak today, especially the people that were like right hands-on with me, Dr. Shurgan, Sheikh, Big Jandal, and my family. They left. I kicked them out of the house so I can be teaching you guys today. And especially you guys, I want to thank you for spending some time. I know time is precious, and I'm super honored that I had your attention for, I don't even know how long. I just kept yapping. So that's about it. I'm all done.
Awesome. That was great, Julie. That was awesome. Thank you so much for sharing. I actually learned something new about you all the time. So I learned a lot of new stuff today. So it was great. Thank you again. So we do have some questions. I guess we'll go questions first, Hashem?
Yeah, I'm good with that.
Okay, so some questions here. So Mark was asking, can a denturist use a diode laser, i.e. for denture sore spots?
For denture sore spots, I would say probably yes, because a denture sore spot is not, you would not treat with your laser in the focused version. You would defocus your laser, which means you're not touching tissue, you're not cutting, you're not there's no incision of anything. So because it's not a form of surgery, they would be able to do it. As a matter of fact, my hygienists will do any form of sores. Anybody who's well trained can do it, obviously, under your supervision. But I would say yes. I don't see why not.
Okay.
Unless there's a rule I don't know. Maybe they are not allowed to own a laser because it can cut, and then the regulation around the cutting part would not be easy to do. But if they do it in a defocused way, I would say there's no problem at all. You cannot harm. As long as they have eye protection, you can't do no harm with this.
The next question that we have is from David. He asks, are there codes for the treatments that you mentioned, such as the disinfecting it for periodontal pockets or ulcer treatment? What codes are there?
I would have to reach out to my fee guide, and to be honest, this is a homework that I've done a little while ago, and now my front desk and administrating team is wicked at this, and I kind of decided to just not even bother with this. But yes, there is. Some of them are in, so if you're going to go do laser for perio reasons, it is in your perio section. There is actually something called debridement or degranulation of pocket with instruments like, and then I think lasers in there, and there's another one that's called disinfection of pocket with adjunct material. It's a bit of a vague thing, but those are the codes you would use in perio to disinfect your pockets. If you are going to remove soft tissue, like that's the dentist that needs to do it. If you're going into removal of tissue of the pocket, now you're going into more of like the degranulation, and there's another one that's called, I think even gingivectomy stuff is included in this, depending on what you're trying to achieve. Yeah.
Excellent. So Mohammed Rana asked, doesn't it take a long time to use a laser compared to the electrosurge for gingival shaping?
No, no, I mean, not much, but electrosurge is just heat. You're burning the tissue. It's just heat. It's the heat at the tip. It's not a light, it's heat. So your heat diffuses to the rest of the tissue around. What else are you damaging? Are you damaging the nerves of your teeth because it's penetrating so darn deep? Electrosurge is a lot more aggressive, and it's basically a burn. Laser is not a burn. It's not heat. It's a light, and it's functioning by, it's a reaction between the light and the tissue. It's a vaporization. It's never a burn. So the penetration is extremely, extremely shallow in the laser. Some of them is like 1 to 2 millimeters at best. So you can go on the tooth all you want or on an implant all you want. You'll never fry that thing. Electrosurgery on an implant, your implant fails. Guaranteed. I don't care what you do, it's going to fail at some point. You just messed up the bone around. It diffuses. The transmission, remember the word transmission I use? That's a penetration and goes. Electrosurgery has a very, very deep transmission. Laser, no, very safe.
Great.
The next question is, can you use a hard tissue laser to cut previous ceramic crowns off?
No, lasers don't cut ceramic or metal. It will reflect and bounce back to your eyes. It won't cut, no. As a matter of fact, if you don't have enough hydration in your enamel, let's say you have an old tooth, you know those teeth that have like retracted nerve, they lack the water supply, they're brittle. You can be with that silly laser on the tooth for so long and you're like, damn it, it's not working. And you think your laser is defective, but what you need to understand is up your water level on your laser and suddenly it rehydrates as you cut and then you penetrate better. So you have to understand the interaction between your tissue and your light. This is a lot of technique stuff, but eventually the more you make your mistakes, the more you try, and the more you sound silly calling your rep thinking it's not working. You bring them to your office and they're like, you just had to up your water, and they're like, okay. Eventually, you know, you get a good feel for it. But no ceramic, definitely not.
Thank you.
Okay, David asked, what's a minimum wattage you would suggest for a machine?
Say that again, sorry, I missed the question.
What is the minimum wattage you would suggest for a machine?
Minimum wattage.
You might be referring to, you know, sometimes they have like a 2-watt laser versus a 4-watt laser. Does it make a difference, perhaps?
It does, but there comes a point where you reach, I think, between 2 and 4, even if you go higher up, it doesn't cut better. Okay. It's not about the wattage, it's more about pulse and the interaction between your hertz and your watts and what tissue you're trying to achieve. Honestly, I don't think I ever go higher than 2, even like when they're frozen. I don't need to. If you go too high, you'll char the tissue. It'll start burning and it'll start melting, and because now you're turning it into an electrosurge almost. I like my laser nice and soft. I prefer to take a bit more time and get like a nice clean, you know, troughing around my crowns with no black, no charring, just perfectly clean. Hemostasis takes a bit of time too. You have to let the time for your hemoglobin to react to your light. It doesn't happen like this. You're not creating a scab. You're basically making those blood vessels shrink and close on themselves. So you need to be patient with laser. It's a fine art, you know. It's a fine art. What it does for you is so beautiful and it heals so well. It's worth, and the patients are excited about it because they have a lot less pain. So no wattage. I would say nowadays what you find on the market, I don't think you can find a laser that has a number of watts that are not high enough to do what you need to do. I think they're all super good. At this point, the companies, a soft tissue laser is a soft tissue laser. I think at this point, it's more the feel of it, the look of it, and if you like those fiberglass that you cut yourself to save money, if you want to use the disposables that cost more money, that kind of stuff is where your decision will be made, not so much wattage.
Excellent, great.
The next question is from Mohammed, and I believe you answered this, but we're going to ask it anyways. Do you need lidocaine before laser usage?
It's a very good question. I would say if I treat anything else than a baby, I do. I have done local anesthesia-free frenectomies on young kids that are 4 or 5 for speech. They react really well. But what they don't like most of the time is the tool you use to lift the tongue. It looks like a little fork. I wish I had a picture in my presentation, but it's a fork that you kind of put like this underneath the tongue, and you have to push and lift. If you think about where your frenum is, if it's a posterior tie, you gotta push hard to go find that damn thing. And it hurts. Like that's the part that they don't like. And that's what I tell the parents when we do frenectomies on babies. I tell them, as soon as I am going to put my tool underneath the tongue, they're gonna start crying. I'm not even started. And the moment I take myself out, they fall asleep. It's done. And then they nurse normal, and then they're happy and they laugh, and then I giggle with them and they're happy babies again. So it's not so much the frenectomy that hurts, it's more the tools that we use. Now, that being said, if you're gonna do a frenectomy on a child that's a bit older or an adult, there's a lot more tissue to treat, and laser diffuses some energy and eventually it builds up some heat. So yes, it can become quite tender. So I always numb a bit when it's children and adults, and I don't numb when it's babies because it's fast and I know they're gonna be uncomfortable for 10 seconds, but the benefits of not freezing way outweigh the risk of not freezing. One, because of methemoglobinemia that can kill them, and two, because when I'm done, I want them to nurse. I wanna go in my nursing room with the mom and I wanna show her that it's fixed. Because that's the wow factor. That's my referral point. That's how I get my clients. That's how I get the moms to cry excited. That's how I get my hugs. So I don't want the baby incapable of nursing after. I want them soothed. I want them happy. I want them not panicked that they don't feel their mouth. So it depends. I guess it's a hit or miss. If it's a very, very posterior tongue tie and it's thick and I know I'm going to be there for longer, I will use a gel called TAC20. TAC20 is a pretty intense form of topical. I do warn the parents about the risk of methemoglobinemia, and I tell them what the signs are and I tell them what to do. It's never happened. I mean, thank God, but it's important to understand those things for sure.
Excellent. So we just have a final question here. It's going to be a combined question, I guess, from both Jeff and Mohammed because they're kind of similar in topic.
Okay.
So they were asking, in essence, are there any brands of laser that you recommend? What's the cost or price point for the soft tissue that you use? Obviously, we know the BioLase ones are, I guess, more expensive than a Picasso or an NV laser. So what are your thoughts on that?
I haven't used so many different brands. I have them demoed in my office. I used to use the Ivoclar Navigator. I really liked it until it just gave up on me because I used it for so long and so many times. And I guess, like I said, sometimes stuff can drop things and it breaks. It's a normal thing to replace it from time to time. Right now I have the BioLase Epics. I love it. I absolutely love it. If I had to buy another one, I don't even think I would shop, to be honest. I would just go right back to that one. It's a very simple laser to use. It's straightforward. It works wonderful. I like it. But I know the NV, so that's a little pen, right? It's like really cool to have. You can have a bunch in the office. You can have one in each up, but they're not as strong. Would I use this on the baby? No, because I want to be super efficient. I don't want this to take time. I don't want to wonder if my Wi-Fi is going to work or not. I don't do the Wi-Fi thing most of the time on babies because I don't want it to fail on me while I'm in there. I have one chance to impress the parents, and this is the one chance. So it has to work or not. I think, I can't remember how much I paid my bio. I think it was like something like 15,000, between 12 and 15, something like this.
Now, if I can help you with that answer too, Julie. You're absolutely correct. It's around there, but it depends on the add-ons that you want to get. So, for example, if you want to have the TMJ add-on and the white,
I have them all, yeah.
These other different things,
Yeah.
there is quite a bit of a premium, and I believe only Sinclair right now in Canada sells the BioLase. Now, I had a very unique experience. I was in Chicago for the Chicago midwinter, and I actually compared the prices in the United States versus the Canadian, including, factoring in the exchange rate as well. And it's significantly less in the United States.
Really?
Yeah, so it was to the point though that I ordered 6 of them, and the Sinclair rep called me and said, well, which office in the United States would you like it? Because I actually had it delivered to the United States, but I paid with a Canadian credit card, right? But then they said, well, no, because you're a practicing dentist in Canada, we only can ship it to a American licensed dental office. But I think that it's a way to get people to not ship, or Canadians not to buy from the United States. So my advice to you, I do agree with you. The BioLace is the best diode laser currently on the market. If you have a colleague or a friend that has a dental practice in the United States, you're probably better off buying it and then just having it shipped over there, having them buy it and you pay them, because you'll probably save at least a couple of $1,000s on it.
Wow, I didn't know. Thanks for the tip.
No problem.
Cool. Awesome. Well, I think that pretty much covers everything that we needed to cover. That was phenomenal, Julie. Again, thank you so much for
my very pleasure.
Everything. It was very insightful. Like I said, I've been using lasers for quite some time, and I definitely learned a lot of stuff today. And I'm sure all our listeners as well are really excited to hopefully implement some of the things that you talked about today in their practices. And I know Julie's very approachable, so anybody wants her contact, she can always reach out to myself at the Ontario Dental Implant Network, or Hisham through Dentistry Academy, right?
No problem at all.
Absolutely. Thank you so much for that, Julie. And I just want to one more time remind everybody of tomorrow's talks. We have Dr. Hassan Mustafa and Dr. Mona Patel at 11 a.m., followed by our 6 p.m. session with Dr. Tina Kokosis. So we're looking forward to seeing you guys all there tomorrow. If you haven't registered yet, dtacademy.ca. Have a great evening, everybody. Julie, thank you so much. You did absolutely incredible, very insightful, and have a wonderful evening. See you guys later. All right, bye-bye.
Yeah. Have a great night.